Showing in front of your slides right now is the important water values. You want to know these guideline values. Again, they are not that difficult. Most of them you already know, and if you look them carefully, you would understand that it is really not that difficult and it would help you in the examination. Because these values are not all the values that are given in the books, they are the important ones, can be tested in the examination. So let us have a look at it. Color, we just saw, should be less than 15 true color units. Turbidity should be less than 5 nephelometric turbidity units. Turbidity should be less than 5 nephelometric turbidity units. Hardness, it should be less than 150 to 300 milligram per liter. So that should be the level of hardness for drinking water. These are criteria for drinking water. pH should be about 6.5 to 8.5. We saw that one of the important reasons we want that pH to be in this range is for chlorine. We want an abundance of hypochlorous acid, and at this pH hypochlorous acid is abundant, and therefore we want this pH. TDS should be less than 600 milligram per liter. Now you would be hearing a lot of people talking about TDS these days. What is TDS? This is not tax deduction at source, but this is total dissolved solids. So total dissolved solids should be less than 600 milligram per liter. Fluorine should be less than 1.5 ppm. We also saw that this is the maximum tolerable level. We would like a level of 0.5 to 0.8 milligram per liter. Nitrates less than 50 milligrams per liter. We discussed nitrates and nitrites yesterday, if you remember. So nitrates should be less than 50 milligram per liter, and nitrites, the dangerous one, the short-lived one, recent contamination nitrites, remote contamination nitrates, so that nitrites should be less than 3 milligrams per liter. Pathogens and viruses, to put the really long story very short, you don't want them. Okay, you have that complicated charts in the book showing you how much do you want in 100 samples and of 100 mLs and a very long thing. But the bottom line is, to really put it simply, it's not practical to remember all those charts, is you don't want them. So you want zero E. coli or coliforms into your water samples. Gross alpha activity, we saw that alpha was the more dangerous one. It has more damaging power, and therefore gross alpha activity has a tighter safety level, and it is less than 0.1 becquerel per liter. And gross beta was not that dangerous, and therefore we tolerate about 1 becquerel per liter. So we want it less than 1 becquerel per liter. So these are the common parameters of drinking water that you would like to remember. The next question is, the noise generated while a jet plane takes off is, and the answer is 150 decibels. The answer is 150 decibels. We saw it would do us a whole lot of good if we remember these noise levels, because they are frequently asked. You can have them in direct questions, or you can have them in the stems. So at least for the extremes, you should know what are the sound levels. Right now, showing in front of your slides is one such table where you have the noise from various things. This is again was covered in the class, and the sound levels coming off those noises. So with that, whisper is 10 decibel, speech 73 decibels, or rather 75 decibels to round it off, and the other extreme, jet taking off, was 150 decibels. If you remember, what was the decibel level at which the eardrum got punctured? It was just 10 decibels above 150, and that is 160 decibels. So at 160 decibels you get a eardrum puncture. That is a very high noise. So jet takeoff is very high on that list and almost close to the rupture. We also saw that there can be a hearing loss with continuous exposure to frequencies of around 4000 Hertz, because that frequency is taxing to the ears, and we also saw that 95 is the cutoff, and after that we have problems with the hearing above that. The next question is, which of the following immunization is recommended in the elderly? Immunization in the elderly? Yes, we do it, although we don't commonly think in those ways. The general perception is that immunization or vaccinations are for the children. Adults and older population don't need immunization, but that is not true. They also need immunization, and there are some specific immunizations which are recommended for the elderly. One such specific recommended immunization is included here, and what is that? The answer is influenza. We saw that there are the shifts with influenza, and then it can cause pandemic, it can spread to a whole lot of people, and we discussed high risk groups, and geriatric population was one of the high risk groups. So they are at risk of having a severe influenza disease. They are also at the risk of having secondary infection if they have infection with influenza, and that can be very serious in them, and it can be life threatening. We don't want that complication, and therefore we immunize them with influenza. So influenza is one of the vaccinations which is recommended in geriatric population. Remember that. Which of the following is a common fracture in the geriatric population? The answer is fracture neck femur. Fracture neck femur is a common fracture, and we are very worried about it. Why is this question put? Because fracture neck femur is common in geriatrics, is not only important in community medicine but also in orthopedics, maybe even in surgery. This fracture is frequently the event which starts that cascade. Fracture neck femur, the blood supply to the head of the femur is, as it is very poor, okay, it is precariously dependent upon the blood vessels coming from the neck. Once that neck is broken, the head gets its blood supply cuts off, it has not got no collaterals, so therefore what happens is it dies. The head gets necrosed, it dies, and therefore it has to be replaced. That operation is a big operation. You have to have a lot of bed rest just because of fracture neck femur, or also after the operation you have bed sores, you have chances of pneumonia, chances of other infections. So, and this sets on a cascade wherein the patient is difficult to recover. So therefore fracture neck femur is a common fracture, and also a fracture we are scared of. So it is a very common fracture because the bones osteoporosis is a very big problem in India. Many people suffer from osteoporosis. Again, supplementing calcium tablets in geriatric population is a good idea, but it is not likely to completely reverse the process of osteoporosis. These bones are laid down very from the beginning, so the calcium levels should be maintained from adulthood. You can't expect the geriatric body to heal itself with a lot of calcium. It is not going to happen that you keep on chewing calciums, but the bones have a tendency, they have already formed, so they have a tendency to keep that composition. So osteoporotic bones have a tendency to fracture, and it is not going to happen that supplementing calcium directly into the old age would suddenly decrease the bone density to the normal levels and everything is fine. That is not going to happen. So take care, calcium supplementation has to be started into adulthood. That is something to remember here. Also, you would like to know that osteoporosis has genetic components. So people have genetic predispositions for fragile or non-fragile bones, or rather dense or non-dense bones. So that was something about fracture neck femur and its importance in geriatric population. The next question is, a 70-year-old man comes to the OPD with complaints of difficulty in micturition. He has to strain to empty his bladder and does not get the sense of completely emptying the bladder even after he is done with the micturition. The condition the person is most likely suffering from is, he is suffering from prostatic hypertrophy. The condition the person is most likely suffering from is prostatic hypertrophy. Why? The first clue that I have is, he's a man. He's a man, he has got a prostate. If she was a female, then this question does not arise. They don't have a prostate and they don't have benign prostatic hypertrophy, in case you didn't know that. So of course we know that only males get BPH, only males can get prostatic cancer because only males have a prostate. So that was my first clue. He's a man, and more importantly he's a old man. The age of this man is 70 years, so he's a pretty old man, and he comes to the OPD with difficulty in micturition, and he has to strain to empty his bladder. Even after straining, he has dribbling of urine. Even after that, he does not get a sense of emptying the bladder. So all these are classical complaints of BPH, benign prostatic hypertrophy, or some people also call it as BHP, benign hypertrophy of prostate, whatever you like. That is the problem. The prostate has hypertrophied, it has grown big, it is compressing on the urethra, and therefore the person is having problems with micturition. Remember your anatomy, the prostatic part of the urethra crosses right through the prostate, and therefore any hypertrophy in that region is liable to compress the urethra and cause these problems. If you have in the stem an old man with these complaints, then definitely he has BHP. Now here you can have a first degree question like you have here, or you can also have a second degree question. Say for example, you can have a question, what is the management for this, or if it is a malignancy, where does it metastasize? So these are second degree questions. So you remember that this can also be there. For us, what was asked was simply the diagnosis, and we discussed that it is prostatic hypertrophy. Stricture urethra, there is no adequate history for that. There is no history of discharge. There is no history of repeated infections. Gonorrhea, again, no urethral discharge, no problems. Urethral septum, if this was there, then it would have manifested long back. Why is the person now coming? The age of the person is 70-year-old. He's pretty old, and therefore I don't see a reason why he should present now with this complaint. And as it is stricture urethra or urethral septum do not classically manifest with these symptoms. The next question is, state-sponsored financial aid to females is given up to how many deliveries? And the answer is, it is given up to 2 deliveries only. Are you happy with that? Yes, indeed, I am very happy with that. Why? If I keep on giving money to people for having children, there are many people who would want to have a lot of children. You know, we discussed children in India are not liabilities. Children in India are assets. In foreign countries, in developed countries, children are liabilities. There are huge costs for raising children. Their expectations are very high. They have to spend a whole lot of money on raising their children. As compared to the Indian children, if you look at the rural areas especially, if you have a child, if you have say 5 children, it means that you are needing 5 laborers less to work on your fields. Those 5 children of yours are going to take care of your field. So you need 5 people less to employ. So they do work, and the money that was going to go to somebody else is now remaining back with the household, and you are happy because you automatically earn money. So these children are a source of earning rather than a liability, and therefore people would want them. Also, birth control is not very high on the Indian list. We know that by the growing population we have. We saw that our population growth rate is very, very high. Still, it has not met any of the criteria that we had set for ourselves. So therefore, we don't want our population to increase more. What we want is that the infant mortality should reduce. Obviously, for reduction of population, we don't want a high infant mortality, so a lot of children die, and we don't have a population growth. That is not the approach that we should have. We should have institutional deliveries. We should have reduction of infant mortality rate, but at the same point of time, we don't want to promote population explosion, and therefore, obviously, yes, state-sponsored benefit is there for institutional deliveries. The objective is infant mortality should come down. Children should be delivered in hospitals, but at the same point of time, I don't want to propagate the population, and therefore the limit is set at 2. Under which scheme is this financial benefit given? Again, into your high yield notes, we had seen a section called as Janani Suraksha Yojana. Janani Suraksha Yojana was the name of the scheme under which money was given to the mothers for having 2 deliveries in the institutions. Remember, money is also given to the ASHA under NRHM, National Rural Health Mission. Janani Suraksha Yojana is a program under the umbrella program of NRHM. So under NRHM, ASHA also gets money to take the pregnant female to the hospital. She also gets money to stay with the pregnant female for a couple of days in the hospital. So she gets money for that, and the mother gets money for getting the delivery done in an institution. So the Janani Suraksha Yojana objectives: reducing maternal mortality and infant mortality by promoting institutional deliveries in especially below poverty level patients. It is 100% centrally sponsored, we saw that, and cash benefit is given up to 2 children. That is how Janani Suraksha Yojana operates. We also discussed that there are cash benefits, but I didn't put those cash benefits deliberately because there are 2 categories. You have a high performing state, you have a low performing state, and the monetary benefits given are different, and it would be again cumbersome to remember those numbers. For those of you who think they can handle that, please go ahead. But if you can't really, it is not very high yield. It's not likely to be appearing into the examination because you have a ambiguity there. The next question is designing of machines, tools, equipment and manufacturing process, layout of the places of work, methods of work and environment in order to achieve greater efficiency of both man and machine is called as indeed ergonomics. Again, you would find this in the definitions part that we covered. This, what I just described, is exactly what ergonomics is. Designing machines to make man's life comfortable and adjusting man to the environment that he has. So adapting the whole environment so that greater productivity is achieved is ergonomics. If you have seen Avatar, which I'm sure you have, if you have seen those robots inside which the human beings goes on Pandora, that was an excellent example of ergonomics. So you move a finger and the machine moves a finger, but the thing is that you can't move a lock with your finger, but the machine can. So that is ergonomics. Ergonomics is basically enhancing man's interaction with his environment and making it easy and more productive. So those were the examples of ergonomics. An example probably you would remember well. The next question is the denominator used in the calculation of crude birth rate is, and the answer is mid-year population. The question answers me. The answer is mid-year population. The question itself answers me. The question says the denominator used in the crude birth rate. Why is it crude? Because I don't have a specifier. That is why it is crude. So the denominator automatically becomes the mid-year population. I can have a lot of specifications there. We saw that general fertility rate, general marital fertility rate. Okay, so all those net reproduction rate, those are specific denominators. That denominator is not present here, and that is why it is called as the crude birth rate, and therefore the denominator would be mid-year population. The next question is, which of the following methods is not used for birth control in family welfare program? The question asks you which of them is not used. All of them are used for birth control, but all of them are not provided by the family welfare program. The ones which are really important would obviously be provided, and the miscellaneous ones are not provided. So the question asks you what is included and what is not included. So here not only you need to know what is a contraceptive method, you also need to know what contraceptive methods are recommended by the family welfare program. And the one which is not supplied by the family welfare program is the vaginal sponge. Of course, you know that condoms are supplied by the name of Deluxe Nirod. You also get a IUD, that is also very commonly done. Vasectomy and tubectomy, yes, very much yes, a big yes to that. We already have a lot of vasectomy and tubectomies being done. So these four are included in the National Family Welfare Program, but this vaginal sponge is not included. Although it is a method of contraception, the success rates are not very high. Its use is clumsy and sometimes it may fail. So we don't do that in the National Family Welfare Program. In market it is available. It is a prevalent method of contraception. But vaginal sponge is not supplied by the government. The next question is, which of the following is most strongly associated with CHD? And the answer is LDL. Okay, the baddie, the bad cholesterol, the bad guy amongst the cholesterols is LDL, and LDL is the bad cholesterol. It is associated with CHD. HDL is the good cholesterol. VLDL, I won't answer because I have a question again on that. The next question is, identifying children at risk of developing high blood pressure in the future is called as. Something you can't afford to miss, something you have to know is this. And the answer is tracking. Again, going back to that wonderful diagram that we saw. Okay, this was tracking. What we were doing? We were taking serial blood pressure measurements of children as they grow, and we saw that children who had less blood pressures initially tend to remain in that lower trajectory. So this guy was here and he tend to remain here. Somebody who has lower blood pressure, his sympathetic tone by default is set lower than as compared to this child who was not hypertensive now, but his blood pressure was more as compared to the peers, and therefore in adulthood he is more likely to develop hypertension. So this is called as the tracking of blood pressure. Somebody who is in the lower trajectory remains lower because the sympathetic tone by default is set less, and somebody who has high blood pressure in the childhood completely goes up and becomes a case of hypertension. It's a wonderful measure because we can have high risk kids screened out initially. So that is called as a tracking of blood pressure. If you know, there was a notable example called by the name of the player Boris Becker. He had wonderfully low levels of blood pressures all the time, and obviously he was a champion, so he had no symptoms. So probably he was one of those kids who was on this line, never really developed a high blood pressure. Which of the following is not used in the diagnosis of leprosy? And of course, lepromin test is not used. A tricky question. When you say diagnosis of leprosy, lepromin test, what else would it do? No, it does not diagnose leprosy. It does a whole lot of things, but it doesn't tell you whether the person has leprosy or not. It tells you if you have hypersensitivity to the lepromin protein, that it can tell you, but it does not diagnose leprosy by any length of imagination. It has got two reactions we saw, the early reaction and the late reaction. Early reaction was called as the Fernandez reaction, and the late reaction was called as the Mitsuda reaction. So those were the two reactions. We also saw those interpretations pertaining to them, but we had emphasized the point that it is not a test used for diagnosis of leprosy. The others can be used. Fine needle aspiration cytology can be used if you have those lepromatous nodules. You can have fine needle aspiration cytology done there, and you can see those lepra bacilli that we saw, globi, and those cigar shaped bundles. Okay, AFB stains, you can see those bacilli, that can be done. Split screen smear, yes, we do that. That is also a common method for diagnosis. We tease the skin, we take out some tissue, we tease that tissue, and then you do a microscopy, you get those clumps of bacilli. Skin biopsy can also be done. So the other things are done, but lepromin test does not diagnose leprosy, something you should remember. The next question is, according to the WHO schedule, treatment for paucibacillary leprosy that has to be continued for how many months? And the answer is 6 months. The treatment for paucibacillary leprosy we saw has to be carried out for 6 months, and the treatment for multibacillary leprosy has to be carried out for 12 months. So these are very long treatments, okay, much like tuberculosis. Paucibacillary 6 months, multibacillary. With that, we finish off this section of MCQs. I'll see you in the next class.